Welcome to my today's classroom. Today I will be talking about upper GI bleeding, clinical approach in a case of upper GI bleeding. Now this upper GI bleeding is very common. Upper GI bleeding means bleeding occurring above the ligament of Treitz. That means any bleeding which is occurring in pharynx is occurring in esophagus, down in stomach and duodenum, that is known as upper GI bleeding. Now a case of upper GI bleeding can present with either hematemesis, patient can present in form of melena, patient may present as a case of occult blood in stool, and sometimes patient presents with hematochezia, that is fresh blood in stool. Now this depends on amount of blood bleeding which is occurring in the GI tract. It depends on that. Whether it is associated with vomiting or not, it depends on that. If patient is presenting with upper GI bleeding and if it is associated with vomitings, that is known as hematemesis. So there are various causes for this upper GI bleeding. I will talk about all these causes one by one and how to proceed in the clinical diagnosis of these cases and how to manage them. Usually the patients of upper GI bleeding, they present with hematemesis in cases of variceal bleeding. In cases of variceal bleeding, usually you will get history of chronic liver disease of any type which may lead to cirrhosis, it may lead to chronic hepatitis, and it is usually associated with portal hypertension. And as a result of portal hypertension, there are formation of varices in the esophagus, and these varices may rupture because of increased pressure and may lead to upper GI bleeding. So in these cases, the patient will present with painless hematemesis. Again, if bleeding is say for about 1000 ml, 500 to 1000 ml, then usually patient present with hematemesis. If bleeding is as small as 50 ml, simply occult blood may be present in stool. And if blood bleeding sometimes is very severe, more than 1000 ml, and transit time is very fast, then in that cases you may get hematochezia in the stool, fresh blood in the stool. Otherwise, you will get melena. So whenever a patient is presenting with variceal bleeding, you can get all these features, either occult blood or hematemesis or melena or hematochezia. Now these patients of variceal bleeding, whenever they are presenting, so you will have to decide from history about the cause of these varices, and then you will proceed further. Further, I will tell you how to proceed in cases of variceal bleeding. Other causes of upper GI bleeding include Mallory Weiss tear. Now this Mallory Weiss tear, it usually occurs because of forceful vomiting, sudden vomiting, usually in cases of pregnancy, in cases of alcoholics. If there is a binge drinking and after binge drinking there is vomiting, then this forceful vomiting may lead to mucosal tear, and from mucosal tear there is frank blood loss, severe blood loss, and it is associated with hematemesis. In cases of Mallory Weiss tear, sometimes bleeding is so severe that patient may present in shock. It may be about 500 ml of blood in the gastric content, and it will come out and may patient go into the shock. After Mallory Weiss tear, later on for 2 to 3 days, melena may persist. So this Mallory Weiss tear, again, it is an emergency condition. It should be managed immediately. So in history, you will get history of forceful vomitings. And after forceful vomitings, there is sudden hematemesis in case of Mallory Weiss tear. Another condition which I have already talked in my previous lecture is Bore-Heave syndrome, Bore-Heave tear. In Bore-Heave tear, there is through and through tear of esophageal wall because of forceful vomitings. But in this case, there is hematemesis, but it is not so profuse. These patients will not present with in the shock because bleeding is not so much severe, because It is through and through tear, and because of through and through tear, sudden muscular contraction will occur and bleeding will cease. In these cases, in Voorhees tear, apart from hematemesis, you will get pressure symptoms because of leakage of acid, blood, and contents of esophagus in mediastinum. Patient will develop mediastinitis and symptoms of pressure will appear. Pressure will occur on heart, pressure will occur on lungs. Patient may develop pleural effusion. So again, this is an emergency condition and it should be dealt with accordingly. So these are the usual causes which are related to the esophagus. Apart from this, erosive esophagitis, pill-induced esophageal ulcer, sometimes these patients cause bleeding and lead to hematemesis. So this should be properly evaluated in order to manage it at a correct time in proper sequence. Now there are many other causes of upper GI bleeding. Sometimes gastric varices, they bleed. Gastric varices bleed similar way. This bleeding is in the same way as esophageal varices. These varices are also formed because of portal hypertension and they will bleed. So in these cases, again you will get history of chronic liver disease, cirrhosis, any type of cirrhosis and chronic liver disease which lead to portal hypertension. So gastric varices, they also bleed in the similar way. They may present with hematemesis, they may present with melena, they may present with hematochezia or simply occult blood. So it depends on amount of bleeding which is happening in the stomach. Apart from this, in stomach, if there is an ulcer, this ulcer, peptic ulcer, acid peptic ulcer, if it erodes the blood vessels, again these patients may develop melena, they may develop occult bleeding, they may develop hematochezia depending on amount of blood loss in the stomach. Even gastric carcinoma, if there is ulceration in gastric carcinoma or if it is invading the blood vessel, then in those cases sometimes there is bleeding. In the same way, in cases of duodenal ulcer, duodenal peptic ulcer, in the same way the bleeding can occur in the duodenum. And in duodenum, if bleeding is occurring, then chances of hematemesis are less. There are more chances of melena, hematochezia and occult blood. So as we go down and down, that is from esophagus down into the stomach, down into the duodenum, the incidence of hematemesis will decrease and incidence of melena, hematochezia and occult blood in stool will increase. So these are the various causes which are usually present in the OPDs and in the emergency units of the hospital. Apart from this, sometimes if there is an ulcer in stomach and if it is invading down towards the aorta or if it is invading behind, then it may sometimes produce severe type of bleeding in the stomach. So these are the various causes of upper GI bleeding, usual causes of upper GI bleeding. Many times in the patients of upper GI bleeding, if they are presenting with upper GI bleeding, they present with severe type of pain in abdomen, and this severe type of pain in abdomen is usually present with acute pancreatitis. Sometimes pancreatic inflammation may reach towards the stomach and there may be a connection between the two and may again produce severe upper GI bleeding. So these are the usual causes of upper GI bleeding and patients may present with this type of bleeding. Now when a patient presents in emergency unit or in OPD, how one should evaluate these patients? First of all, examine the vitals. First of all, examine the pulse, examine the blood pressure. If there is fall in blood pressure, systolic blood pressure, and fall in supine and standing position is more than 20 millimeters of mercury, that is, whenever there is postural hypotension, fall in systolic blood pressure is more than 20 millimeters of mercury, then it means the bleeding is severe. It is more than 250 ml blood. Whenever bleeding is more than 250 to 500 ml, patient will develop postural drop. postural hypotension. So postural hypotension is one of the features of blood loss. These patients of upper GI bleeding, they present with dyspnea, they present with giddiness, they present with vertigo, they present with features of weakness and lethargy if bleeding is chronic. So whenever such type of patient reaches OPD or emergency unit, first examine the blood pressure. If all is of systolic blood pressure is more than 20 millimeters of mercury on standing, that means definitely there is blood loss. Then always measure the hematocrit value. If hematocrit value is falling, if it is falling to by more than 25%, that means definitely there is a bleeding and one should manage that bleeding immediately. Many a times these patients may present in shock. So first thing is that you will have to measure blood pressure and vitals. Then keep all the intravenous lines patent by introducing wide bow catheter so that you can transfuse blood and IV fluids easily. As soon patient reaches the intensive care unit, these patients should be kept in intensive care unit. So whenever the patient reaches intensive care unit, before making a diagnosis, always manage the emergency. Blood loss. First you manage this blood loss. In managing the blood loss, if there is severe blood loss, say of more than 300 ml, 500 ml, then in those cases immediately arrange for blood transfusion. Before blood transfusion is arranged, you start with plasma expanders, ringer lactate, normal saline. These should be infused immediately. Now when we give these IV infusions, in those cases, when you measure the hematocrit, this will further fall down because of hemodilution. So in cases of during management, if you measure the hematocrit value, it is less of significance because it will gradually go down and it will only come up after giving blood transfusion and stopping the intravenous infusions of linger lactate, normal saline and plasma volume expanders. So first of all, you will have to manage on these lines. Once patient becomes stable and if you are getting history of chronic liver disease, if you think that probably the bleeding is because of varices, it is from esophageal varices or from gastric varices, you immediately give a bolus of octreotide somatostatin. Octreotide, this is a synthetic somatostatin. So octreotide is given in the dose of 100 milligram bolus, and then you will infuse octreotide in the dose of 50 microgram per hour, and this is continuously given for 3 to 4 days after the bleeding ceases. Meanwhile, you will do other investigations to see the position of varices, what is the condition of varices, what is the exact condition of varices which are bleeding. So first you will start with octreotide if you think that bleeding is because of varices. If you think that bleeding is because of Mallory-Weiss-Steer, then in that case simply you will start blood transfusion and symptomatic management with volume expanders, plasma volume expanders and IV fluids. Meanwhile, as soon bleeding ceases, you will go for diagnostic procedures. If patient is of Voorhees-Steer, then in that case, in Voorhees syndrome, immediately this is a surgical emergency. So immediately investigation should be done and surgeon should be called for further management. If you think that bleeding is from peptic ulcer, then again you will have to manage it accordingly by giving proton pump inhibitors and local anesthetics to get relief from pain and to stop bleeding. Plus, you will have to do further diagnostic procedures. Usually, Ryle's tube is introduced as soon the patient comes with upper GI bleeding. Usually in cases of bleeding of peptic ulcer or gastric erosions, in these cases Usually a Rayleigh tube is put inside the stomach and gastric lavage is done. By doing this gastric lavage, we can further make endoscopic view easy, so that the stomach will clear off and you can visualize it easily with the endoscope. So this is how we will proceed. Similarly, we will proceed if you in the duodenal bleeding. If there is past history of duodenal ulcer, or you think from history that there is acid dyspepsia for a long time and patient is bleeding because of this duodenal ulcer, then you will manage it accordingly with proton pump inhibitors, sucralfate like agents which give the healing effect. So like this, you will proceed in a case of upper GI bleeding by doing this general examination and maintain the vitals. You will have to maintain the vitals. Now, after this comes the diagnostic procedures. If patient is coming with upper GI bleeding, you will have to diagnose what is the exact cause, what's the exact pathology which is producing this upper GI bleeding. So for this upper GI endoscopy is 100% specific and sensitive. So upper GI endoscopy must be done in these cases. With the help of upper GI endoscopy, you can see the esophageal varices. Now, these esophageal varices on upper GI endoscopy, they are classified into three types. One is grade 1 esophageal varices, grade 2 esophageal varices, and grade 3 esophageal varices. Usually, patients with bleeding, they present with grade 3 esophageal varices. These are also known as F3 varices. Now, these bleeding varices, they can be clearly seen bleeding through the endoscope. Sometimes signs of bleeding are present. Bleeding has stopped, but certain signs are present. One of these signs is cherry red spots. These are red colored spots over the varices. And in this grade 3 varices, F3 varices appear like bunch of grapes. And over bunch of grapes, there are multiple cherry red spots. Sometimes the one sign is there known as whale sign. This whale sign is positive. Now this whale sign has nothing to do with whale fish. Whale sign, whale is a small village somewhere in the Scandinavian country on the sea coast, and its aerial view, appearance of its aerial view is similar to this F3 varices. So it is known as whale sign. So if whale sign is positive, if cherry red spots are present and bunch of grapes of esophageal varices is present, this suggests that there is liability to there is tendency to bleed, or already it has bleeded. So if you have confirmed that it is the esophageal varices which are bleeding and has caused the upper GI bleeding, then in those cases you will have to do immediate endoscopic variceal ligation. In past, sclerotherapy was done, but nowadays sclerotherapy is not done. More easy procedure is esophageal variceal ligation. This esophageal variceal ligation is done with the help of endoscope, and varices are ligated down from the gastroesophageal junction up towards the upper part of esophagus. One by one, they are ligated. So with the help of this procedure, with the help of this esophageal variceal ligation, you can stop the bleeding. This can be done as emergency procedure. If varices are clearly visible, then only you can ligate them. Now, if in upper GI bleeding, if varices are present in esophagus and together with that gastric varices are also present, then in these cases you will have to do two procedures. One, esophageal variceal ligation, and second procedure is injection of glue in gastric varices, because you cannot ligate those gastric varices with the help of endoscope. You cannot ligate those varices. Chances of bleeding are more if we ligate those gastric varices. So in those gastric varices, you inject glue and you ligate esophageal varices. Otherwise, if you simply ligate only esophageal varices, then there are chances of bleeding of gastric varices. There are more chances of bleeding of gastric varices, and bleeding may be more severe. So like this, you will proceed in the treatment of gastric variceal bleeding. Now, if still the esophageal variceal bleeding is not stopping, it is not ceasing, then in that case, you will have to reduce the portal pressure by doing TIPS, transjugular portosystemic shunt. In this procedure, a metallic shunt is introduced through the jugulars down into the liver, and there in the liver the shunt is placed between portal and hepatic and the systemic vein. With the help of this, you can provide a portosystemic shunt, and you can reduce the portal pressure, and variceal bleeding will stop. The only side effect of TIPS is hepatic encephalopathy, minimal hepatic encephalopathy, subclinical hepatic encephalopathy, which you can manage clinically very easily. So like this, you will manage variceal bleeding. On the other hand, if there is a Mallory Weiss tear, say if there is a tear in mucosa at the lower end of the esophagus, and if it is bleeding profusely, then you will have to manage it accordingly. You will manage by giving blood transfusion, IV fluids in the same way, plus you will have to manage that Mallory Weiss tear, though in most of the cases bleeding stops by itself. But if it is not ceasing, then in that case, with the help of one sewing device, you can sew that area with the help of endoscope, that is known as endoscopic sewing, or you can do electrocoagulation of that area. But one of the side effects of electrocoagulation in the esophagus is development of stricture. Many a times stricture may develop. So in these cases, in the case of Mallory Weiss tear, with the help of sewing device, we can sew that area. With the help of upper GI endoscopy, you can diagnose the Voorhees syndrome. If there is Voorhees tear, then you can immediately call surgeon for doing further surgical procedures. Further, when you move down into the stomach, you can see bleeding gastric ulcer. If the gastric ulcer, gastric peptic ulcer or carcinomatous ulcer is bleeding, in that case, you can see a clot of blood or white colored base of the ulcer, or a clot adhering to the base of ulcer. If you try to remove this clot, then bleeding will again suddenly increase, because this clot formation is at the level of, at the site of blood vessel which is bleeding. So sometimes by natural mechanism, a clot is formed in that area which will cease the bleeding. So if you try to remove that clot with the help of endoscope, bleeding will further increase. Now if bleeding is occurring, if you are seeing that bleeding is occurring there, then in that case you can apply clips. There are certain clips, endoscopic clips. You can apply clips in that area, or you can perform electrocoagulation. So these two procedures can be done to cease the bleeding of ulcer in the stomach. Similarly, in the cases of duodenum, if there is bleeding, then you can put clips which will cease the bleeding in the bleeding duodenal ulcer. Similarly, in the same way as stomach. Now, sometimes erosions, gastric erosions, in cases of erosive gastritis, there is severe bleeding. But this erosive gastritis, in these cases, simple symptomatic management can stop the bleeding. So this is how we will manage with the help of endoscope the cases of upper GI bleeding. Now, many a times in these cases of upper GI bleeding, this is because of some hematological disorders. Then in that case, you will have to do hematological studies to rule out any bleeding diathesis. Now, whenever patient comes with such type of bleeding, apart from endoscopy, always do platelet count always do prothrombin time, partial thromboplastin time. And if there is any abnormality in the cases in these parameters, then manage it. Say suppose if prothrombin time is prolonged, then in that case you will have to give fresh frozen plasma in order to stop bleeding. Usually such type of cases are seen in chronic liver disease where prothrombin time is prolonged. Similarly, if platelet count is decreased or there is thrombocytopenia, usually in cases of chronic liver diseases with portal hypertension because of hypersplenic syndrome, there is decrease in platelet count, and because of decreased platelet count, many times there is severe bleeding. Bleeding will further, this will add to the bleeding. So you will have to give platelet infusion in these cases. So one by one, like this, you will have to manage these cases. So this is all about upper GI bleeding and how to manage the case of upper GI bleeding. Thank you.